For our last lab together, we'll be doing urine cultures. Before lab, you'll be collecting a random urine in a container that I supply. There's no special preparation needed for this. Simply urinate in the provided container. Don't fill the container. We only need about 1/4 to a half of the container. And when you instruct patients to collect a urine, the same thing is going to apply. It is not necessary to fill the container. You'll also collect a clean catch midstream urine, abbreviated as CCMS. You'll be given 3 wipes and a sterile container. Follow the directions given in the lab manual. If you are unable to collect this specimen immediately before lab, if it's more than 30 minutes before lab, you should refrigerate it. If you're at home, you can refrigerate it and bring it in. If you are on campus, you can bring it up to the lab and put it in the refrigerator in the lab. The first thing that we'll be doing on the urine is a culture and sensitivity test. A culture and sensitivity can only be performed on a specimen that has been collected aseptically in a sterile container. If it has not been collected in a sterile container, it will be rejected by the laboratory. If a urinalysis is also ordered, both can be done on the same specimen, but the culture must be done first to avoid contaminating the specimen. Once the culture is done by the microbiology laboratory, then they will send it to the chemistry laboratory to finish the urinalysis. The urine culture is typically performed using an all-purpose medium, a medium that is differentially selective for gram-positive cocci, and a medium that is differentially selective for gram-negative bacilli. This covers all the bases of the organisms that could cause a UTI. The all-purpose medium that we'll be using is tryptic soy agar. Blood agar is typically what is used in a clinical laboratory. We'll be using Columbia nutrient agar in order to isolate gram-positive organisms, and either EMB or McConkey agar to isolate the gram-negatives. You met both EMB and McConkey agar during exercise 8 when we culture the food samples. A urine culture is performed by using a very, very small amount of urine. We use a loop that will hold 1 microliter. 1 microliter is 1/1000th of a milliliter. We dip it into a well-mixed urine specimen up to a certain point on the loop. And you'll see that this is a very, very small amount of urine that we need. The contents of the loop are then painted down the middle of the plate. Then we are going to streak in one direction, turn the plate, and streak thoroughly in the second direction. This is going to make a lawn of bacteria. We'll repeat this with the other plates that you're going to use, and you have to dip into the urine for each plate, but don't dip into the urine when you go to turn the plate around. The procedure is repeated with the other agar media, and they're incubated for 16 to 24 hours at 37 degrees Celsius. You are going to perform a culture on a simulated patient urine, your random specimen, and your clean catch midstream specimen. After incubation, you'll be observing the all-purpose medium to determine how many colonies are on there. We refer to the colonies as colony-forming units because each colony represents a single bacterium that fell onto the agar dish during inoculation. We will count the number of colonies on the all-purpose medium and multiply by 1,000. The reason we multiply by 1,000 is that we put 1/1000th of a milliliter of urine on the plate. So in order to convert this into a full milliliter, it's necessary to multiply by 1,000. So if there are 10 or fewer colonies on the plate, this represents less than 10,000 colony-forming units per milliliter. This means that there is normal distal urethral contamination and does not indicate a urinary tract infection. When we count between 10 and 100 colonies, this translates to 10,000 to 100,000 colony-forming units per milliliter. This is suspicious. So now we'll take a look at the other plates, the Columbia nutrient agar and the EMB. If we see growth on both the CNA and the EMB, the high count is likely due to poor collection. the clean catch midstream wasn't done properly, or the specimen may not have been refrigerated after it was collected. If we see only a single organism, for example, we see 100 colonies on, or 90 colonies on the CNA, but nothing on the EMB, then that's suspicious of a urinary tract infection getting started. If we see greater than 100,000 colony-forming units per milliliter, or greater than 100 colonies, this will signal a urinary tract infection only if a single organism is observed. If again we see colonies growing on the CNA and on the EMB, even if there are greater than 100, this is a mixed specimen. So it either means that a clean catch midstream was not done properly, or it means that the urine was not properly stored after collection. Presumptive identification may be made after incubation simply by looking at the colonies, but biochemical testing is necessary for positive identification. Biochemical tests and susceptibility testing can be set up at the same time with some products. This microscan plate, for example, can do both an MIC and an identification of the microorganism at the same time. Expect the lab to take 48 hours after receiving the specimen for a complete identification and sensitivity result. For example, here you'll see in this result that comes back from the laboratory that Staphylococcus aureus was the organism that was identified. The antibiotics that are going to be listed down the side, the MIC will be given, and then the interpretive category, resistant, susceptible, or intermediate, will also be given in this patient report. The complete urinalysis can be performed on any specimen, sterile or not. This requires about 15 milliliters of urine. There are 3 components to the complete urinalysis: the physical, the chemical, and the microscopic examination. It's important that the 3 components correlate with one another. The urinalysis can give clues about the person's health, diabetes, infection, or malnutrition, and urine is the most common specimen that is analyzed in the laboratory, primarily because it is easy to collect. It's a non-invasive procedure. The physical analysis begins by looking at the sample in a clear container. The first thing we look at is color. Normal urine color ranges from pale yellow to amber. The more hydrated you are, the lighter the urine is going to be. Color is going to be affected also by the food you have ingested. If crystals are present and they precipitate, which they will do as the urine cools, and medication. You know, often after you take your vitamins, your next urination is often a yellowish green color from the vitamins that you've ingested. Colors that indicate possible pathology include red, which is the presence of blood, brown, which is the presence of hemoglobin or myoglobin. This may come from muscle damage, and dark amber is also indicating that hepatitis is a possibility. Once we've analyzed the color, then we'll look at the turbidity. Normal urine is clear. Turbidity or cloudiness can be due to the presence of cells such as epithelial cells, sperm, bacteria, yeast, white blood cells, or crystals. The cause of turbidity will be revealed in the microscopic analysis. Turbidity typically is reported as clear, 1+, 2+, 3+, and 4+. The urine on the left is considered to be a 0, which is clear. This urine on the right would be a 4+ turbidity. Next we determine odor and foam. Odor and foam usually are not reported unless it's remarkable. The normal odor of urine is aromatic. Abnormal odors include ammonia, which is due to bacterial conversion of urea to ammonia. If you smelled a baby's diaper, it hasn't been changed for a while, you know what this smells like. A foul smell is due to a bacterial infection, and a sweet or nail polish remover smell is due to ketones in the urine, and this is seen in poorly controlled diabetes or in starvation. When we detect ketones in the urine, we want to be sure that we keep the cap on it tightly because ketones do evaporate, just like nail polish evaporates. Foam upon shaking is usually not reported unless it's remarkable. Normal foam in urine is white. If we see a greenish-brown foam, this is due to bilirubin, which indicates possible hepatitis. Take extra caution with a urine like this. The chemical analysis is the next portion. The chemical analysis involves a multi-sticks reagent strip, and it is dipped briefly in well-mixed urine. It is important that the dip is brief and that all pads are moistened. Too much urine will cause the reagents to run and mix with adjacent pads. Dipping excessively will cause leaching of the reagents from the pads. Timing must begin immediately after the dip. You will compare the test pads to the color chart on the bottle at the appropriate time intervals. It's very important that you do not touch the strip to the bottle. The strip has urine on it, and you don't want to contaminate the bottle because other people will be handling this bottle. I like to place the strip on a paper towel and then hold the bottle parallel to it with the non-dominant hand, roll the bottle around while I'm comparing the color and writing my results with my dominant hand. Glucose is read at 30 seconds. Normal value is negative. Glucose will be found elevated in the urine during periods of stress and after a large meal or in diabetes. At 30 seconds we also read bilirubin. Normal is negative, and bilirubin will be found in liver disease and hemolytic diseases. Urine with bilirubin is likely to appear amber or dark color and often can reflect hepatitis. Ketones are read at 40 seconds. The normal value is negative. Ketones can be elevated in diabetes and starvation. Remember, this should correlate with odor. Specific gravity indicates the concentrating ability of the kidneys. This is read at 60 seconds. The normal range is 1.003 to 1.030. This may differ depending upon the laboratory you're working in. Darker urine is going to have a higher specific gravity. It is more concentrated. Light urine with a high specific gravity may indicate diabetes. Check the glucose on the strip. If the glucose value is high, but the urine has a high specific gravity and it is clear, it is probably due to diabetes. Next is blood, which is read at 60 seconds. There should be no blood in the urine. There are two ways that blood will be detected in the urine: hemolyzed as hemoglobin or non-hemolyzed as intact red blood cells. If the pad is speckled, this means there are non-hemolyzed blood cells. If the pad has a consistent color, the cells have been hemolyzed. Blood in urine should correlate to the color of the urine. If there is a high blood value, then the urine is going to have a pinkish tinge, and microscopically we should see red blood cells if we have non-hemolyzed blood in the urine. pH is read at 60 seconds. Normal has a pretty broad range, anywhere from 6 to 8. pH is something that we look at to diagnose urinary tract infections. It will be on the high side, around 8, in a UTI because bacteria, which are in the urine, are producing ammonia, and ammonia is basic. Protein is read at 60 seconds. The normal value is negative to trace. Protein will be increased in kidney disease and also toxemia of pregnancy. Urobilinogen, which is a byproduct of bile breakdown by feces in the intestines, is read at 60 seconds. The normal value is 0.5 to 1 milligram per deciliter. Urobilinogen will be increased in liver disease. Nitrite is read at 60 seconds. This is the same test that you did in the Enterobacteriaceae lab. Normal value would be negative. If there are bacteria in the urine, the nitrite is going to be elevated. It will be elevated in a urinary tract infection because UTI bacteria convert nitrate to nitrite. Bacteria will be seen in the microscopic. If the person has a UTI, we will also see white blood cells. Seeing bacteria in the absence of white blood cells typically means that the urine has been sitting out and wasn't refrigerated properly after collection. Leukocytes or white blood cells will be read at 2 minutes. There should be no leukocytes in the urine, but leukocytes will be elevated in an infection, in a urinary tract infection, and white blood cells will be seen in the microscopic. Mixed urine then is decanted into a conical tube and centrifuged at 10,000 RPM. We'll be putting 12 milliliters of urine in the tube and centrifuging it for 10 minutes. After which, we will empty out the supernatant and keep the sediment. The sediment will be resuspended in a drop of a special stain, a Sternheiner-Malbin stain, which is called SETI stain. The urine then will be mixed, the urine sediment will be mixed with the SETI stain, and a drop will be placed on a slide and covered with a cover slip. In a clinical laboratory, we would use a standardized slide like you see here. This slide that you see will hold 10 specimens. We begin our observation at low power, which is 100x. We'll scan the edges of the cover slip for casts. Casts actually come from the kidneys, and because they are large, like rigatonis, not that large, but they're large, they're going to be squished out to the edges of the cover slip. The cast that you see here is clear, it looks like a rigatoni, and these are hyaline casts. These are normal. They are often elevated in athletes. All other casts that you would see, other than hyaline casts, are considered to be pathologic. This one that you see here is a red blood cell cast. This indicates kidney disease. Don't confuse clothing fibers with casts. On the right, you see clothing fibers. We report casts as average number per low power field. So we would count 10 fields, count the number of casts in those 10 fields, and divide by 10. That's the average number, and report that per low power field. Next, we move to the center of the preparation and look for epithelial cells. Epithelial cells will be stained a light blue with a dark blue nucleus. Because there are often many, especially in females, we typically don't count them. We'll report them as 0 to 4 plus per low power field. What you see in this field, I would record as a 3 plus per low power field. If the entire field is covered with it, this is a 4 plus. If you squish them all together and half the field would be covered, that would be a 2 plus. We then move to the 400x magnification, to high power, or the 40x lens. We begin looking for things such as crystals. Most crystals that we see in urine are non-pathologic. Crystals are going to precipitate when the urine cools, and often they will form a coating at the bottom, a sediment of the bottom of the urine. Sometimes this is pink. Amorphous phosphates and amorphous urates under the microscope at high power sort of look like specks of dirt all over the place. Calcium oxalate looks like envelopes, and these are commonly seen in individuals who eat a lot of fruit. Triple phosphate, which look like coffin lids, are normal crystals. Ammonium biurate indicates that the urine is old. And sulfonamide is a crystal that is seen when a person is taking a sulfa drug, such as Bactrim for a urinary tract infection or trimethoprim sulfamethoxazole. Typically, these crystals, non-pathologic, are not enumerated unless there are many of them, making it remarkable. We continue with looking at crystals, looking for those that are pathologic. Pathologic crystals signal disease. Leucine crystals are seen in liver disorders in which amino acid metabolism is impaired. Tyrosine, these spiky crystals, are seen in tyrosemia and in certain liver disorders in which amino acid metabolism is impaired. Bilirubin crystals are seen in liver disease. Cystine crystals are seen in the inherited condition known as cystinuria. Cystine crystals are the most frequent cause of kidney stones in urine in children. Cholesterol is seen in nephrotic syndrome. The cholesterol crystals look like broken panes of glass. In this image you can see two other things. These are epithelial cells, and here you see a white blood cell. These are the cholesterol crystals, which look like broken panes of glass. Pathologic crystals are enumerated and reported as the average number seen per high power field, or HPF. Continuing at the high power magnification, we'll look for cells. Red blood cells can be seen anywhere up to 3 per high power field is considered to be normal. The strip is not sensitive enough to detect that few of red blood cells in the urine. We report red blood cells as the average number per high power field, and this should correlate with the chemical analysis. If you see this many red blood cells in the urine and they are intact, then this should correlate with the strip showing non-hemolyzed red blood cells. Red blood cells have no nucleus, and in this image you see some of them are spiky, which means they've lost some fluid, indicating that they are in a hypertonic solution. White blood cells can also be seen. 0 to 3 per high power field is considered to be normal. Here the nucleus will be visible, and sometimes it even glitters. We see these increased in infection. They are reported as the average number per high power field, and this should correlate with the chemical analysis. Any more than 3 per high power field should show up as a positive leukocyte test in the chemical analysis. Bacteria should not be present in the urine. We do see them elevated in a urinary tract infection, or if the urine has not been collected or stored properly. This should correlate to turbidity and also to the nitrite test. Typically we do not enumerate them. Most of them are modal, so it's hard to count. So we report them as 0, 1 plus, 2 plus, 3 plus, or 4 plus per high power field. Yeast will be reported. We don't expect to see yeast. Yeast may come from vaginal contamination. And here not only do you see the budding yeast, but you also see the hyphae that this yeast will be producing. We also might find artifacts in urine. That's a fancy word for junk. Artifacts are not reported. Clothing fibers, for example, could be found in the urine. Talc, which typically comes from the gloves from the technician that is handling the specimen, will be seen. These look like button pillows that you put on your sofa. Mucus threads are very common in females. Don't confuse mucus threads with hyaline casts. They are much, much smaller. And air bubbles might be seen. This black sphere here is an air bubble. In the background are amorphous urates, and these are normal crystals. Don't forget to bring your urine in for lab, and see you in lab.